Well, hello everyone, and welcome to today's webinar. This is Rick Import for Orchard Software, and our webinar today is 50 Shades of COVID-19 Testing and the Need for Speed. And our presenter today is Matt Modleski, Executive Vice President for Business Development with Orchard Software, and our session is sponsored by our good friends at Orchard. Okay, let's move now to our featured presenter. As Executive Vice President of Corporate and Business Development at Orchard Software, Matt Modleski is responsible for strengthening Orchard's corporate relationships and bringing additional value through new business opportunities. Previously, Matt led the operation of more than 70 physician practices and was a key member of the executive team at American Health Network. From 2006 to 2014, he was a partner at Stovall Granger Modleski, a healthcare consulting firm with expertise in the healthcare environment and competitive positioning. Prior to his work in healthcare sales and marketing, Matt was an accomplished pilot in the U.S. Air Force. He was awarded the 355th Wing Instructor Pilot of the Year and was also a solo pilot on the United States Air Force demonstration team, the Thunderbird. So it is a real pleasure to bring to our microphone Matt Modleski. I will open your mic. You have control. Welcome to you, Matt.
Rick, thanks so much for the very kind introduction. I appreciate it. I hope everybody's doing well out there. I have to give Kim Futrell a big shout out. She's a member of our marketing team. First of all, for the title, 50 Shades of COVID-19 Testing. It will not be as exciting as the book, I'm sure, but probably lured a few of you this way. And then, of course, the need for speed, having flown airplanes, and the movie Top Gun made the phrase famous. We won't be talking jets either, but what the heck. I guess we lured some folks together to talk about a topic that really we do need to spend some time on. That is the need for speed as it relates to COVID-19 testing. And so let's focus on what we are going to talk about today. We're going to talk about the history and progression of COVID-19 testing from sort of big iron reference lab PCR testing through point-of-care testing. We're going to talk about COVID-19 testing challenges and roadblocks, and you as members of the healthcare community and lab community are certainly familiar with all of those, but we'll pull that information together and look at it as a group. We'll evaluate the importance of rapid results in disease management, and specifically as you think about contact tracing and the objectives of pandemic management, they are a little different than maybe some of the way we think about normal lab results. So we'll talk a little about that, and that will lead us to the fourth objective, which is identifying the role of integrated point-of-care testing in the COVID-19 pandemic response. And finally, I'll say last but not least, recognize the lab's vital role and its future role and outlook in this and other pandemic management. Said another way, we love you as laboratorians, and I think sometimes lab sits in the background of healthcare. It certainly isn't today, and we'll make that point several different ways. So thanks for attending. Let's hop right into the content. First of all, we're going to mention vendors, we're going to mention tests, we're going to mention things that by the end of the time I'm talking will probably be obsolete. The COVID-19 situation is so fluid with new changes, new rules, new reporting almost on a daily basis. So we certainly aren't endorsing any products. We're simply using examples of products that exist in the market or have been pushed to certain sectors of the market, for example, skilled nursing facilities, gifts from the government. So we'll talk specifically about some of those as well. All right, so let's hop right into some of the history of COVID. Well, it hasn't all been great history, but in the big scheme of things, we wanted to put the virus in some sort of context. So it is a novel virus, meaning new, but it's got cousins that we've dealt with previously. Since 2002, we've had 3 serious coronavirus outbreaks. The first was SARS in 2002, then along came MERS in 2012, and now COVID-19. The 1918 flu pandemic, H1N1 pandemic, just to, again, for some context in terms of scale, About a third of the world's population was infected in that pandemic, about 500 million people, and as many as 50 million died, although the record keeping wasn't as detailed as it is today. The normal flu on a yearly basis in the U.S. kills between 12 and 60,000 people, and globally between 290 and 650,000 folks. So if you think about it in that context, the the COVID-19 pandemic is not in the same zip code as the 1918 pandemic, but it is clearly more contagious and more deadly than what our normal flu would be in an average year. So let's take a look at the timeline of how this sort of came into our world and has changed 2020 forever, and probably most of 2021 as we think about it. So the first case detected in Wuhan, China was in December of 2019. It seems like it was longer ago than that. But January 30th, the World Health Organization declared a global public health emergency. By March 11th, COVID-19 had been classified as a pandemic. By May 28th, the U.S. death toll passed 100,000, and just recently in September, past 200,000. The last bullet we had on this slide, June 10th, cases reached 2 million. So 2020 has been a crazy year by every measure, whether lab or healthcare or simply being, a member of almost any society. And, we're part of getting it right as we move forward, which is, again, one of the reasons that lab medicine has moved so much to the forefront of every conversation. So you think about testing, we've tested and tested and tested, and you can see, I'm not going to go through this graph, but the slide obviously tells two stories. One, the positivity rate as you expand testing is really important, and red on this slide is bad. Greater than 20% positive tests, regardless of how many you're doing, is not a good stat. If you could get gray lines with a lot of tests, that's what would be optimum. So orange is better in the 3 to 10% positivity rate. Obviously, gray and black, you're getting down into a rate that is very, very good. And as long as the testing volume's high, those are good things to see. So let's talk more about testing as a whole. Something to look at, I think, that's important is the testing timeline that rolled out here in our country. So starting at the bottom of this slide, in February 2020, we had one test performed at the CDC, which was allowing less than 100 samples a day to be processed, and it wasn't a very good test. So starting from there as our baseline, by the time we got into early March, and this is, into March is a pretty cool story for innovation in the U.S. and really kind of a pat on the back to lab scientists. By the time we were in March, just a month later, LabCorp and Quest announced PCR tests available, and labs all over the country shortly thereafter that were properly equipped to perform these highly complex molecular tests were developing approved tests also. So in a month to a month and a half, once we turned our lab scientists loose to develop and run these tests, we had good tests up and running. And then, of course, the problem became volume and demand. And so shortly after March and the labs came online running these complex tests, demand outstripped supply. We've still struggled, and we'll talk more about this, with the supply chain regardless of who's running the tests. But by late March, we got into the EUA issuance of many, many tests and analyzers being approved. So you can look up in the upper right-hand box here. There's greater than 200 FDA emergency use authorization approved tests available. The challenge with that is, the overall reliability of those tests. And so, we have certainly ramped up testing capacity in almost a miraculous way, considering where we started. And there's still work to do, right? So there's still work to do. It's not like that didn't come at some price, though. And so this slide shows what happened to test volumes outside of COVID by hospital. Now, this is hospital labs. The outpatient lab volumes dips were actually greater than these by a little bit. So the bottom line is if we look at March and April and into May, and for all of you who were in the healthcare world during those months, this makes complete sense. Inpatient volumes dropped. Outpatient testing almost went to zero for a short period of time, felt like it anyway. And people stopped, moving as we were sort of told to stay home, and no one went to see physicians. So fortunately, that lull didn't last too much past sort of mid-April, and the volumes came back, and everybody learned how to use telehealth, and we got labs ordered and drawn, and our volumes are coming back up both in the inpatient setting and in the outpatient setting. And of course, if you've chosen to jump into COVID testing, that volume is additive on top of some of the volumes that maybe you were already running. So takes us to the next thing really to look at, which is different types of tests. And there are really sort of three buckets that I think we look at: molecular, antigen testing, and the serological. The most important thing here is each category has different clinical utility, different specimen types, different characteristics and limitations. All of these are available now as a point-of-care test, which is interesting and important as we start thinking about the second half of the title today, which is the need for speed. Now, typically, if I had an audience of laboratorians together, I would look you in the eye right now and I'd say, okay, now I'm not talking about you, but I'm talking about somebody you met at your last conference. How many of you historically have not maybe put point of care in the category of my best choice for a test? And I know we're laughing, or maybe laughing a little bit. There is sort of context required as we think about point of care testing in the integrated approach we need to manage a pandemic. Historically, laboratorians have shied away from point of care tests being put on the same, page as sort of big iron tests that are typically very, very, very accurate. So all joking aside, your lab expertise is absolutely required to educate people who need to be shown, right, and told that these point-of-care tests do indeed have a role in the pandemic management. And that's the objective, right, to keep sick people away from healthy people long enough that they can recover without spreading the disease. And so speed does matter. So some examples of the point-of-care tests that are out there. So Cepheid has a test that's 98.3% accurate on the positive side and 100% on the negative side with a turnaround time of 30 minutes. The Abbott ID Now, which was out early, 88% positive and 100% on the negative with a turnaround time of 5 to 13 minutes. Abbott obviously came out with, after some early, I think there was some early feedback that maybe it wasn't working as advertised. And again, this is important for us as lab experts. While we understand no test is perfect, Abbott came out with this statement: test outcomes depend on a number of factors, including patient selection, specimen type, collection, handling, storage, transport, and conformity to the way the test was designed to be run. Again, I don't think anybody's making the claim or wants to make the claim that this is equivalent to the most accurate tests we can run, but it matters in terms of the way samples are handled, who does the testing, et cetera, that all of these instruments are run the way they're supposed to be, and your expertise is key in helping us manage that up. So thought that was worth putting in there. Couple more types of tests, and now we're getting into the types of tests that the government has graciously sent to our skilled nursing facility folks. And I know some of you are smiling because, whenever the government sends something to you, there's usually a few rules that come with it, which we'll talk to in a little bit. But the Quidel Sofia, 80% positive agreement and a turnaround time of 15 minutes. The BD Veritor, an 84% positive agreement, 100% on the negative side, a turnaround time of about 15 minutes. We'll look at two more, the Lumira 97 and 97 with a turnaround time of 12 minutes. And then this is interesting, the new test that's also come to the nursing home world from through the government, the Abbott Binax now. This test actually, if run by a Navica-enabled test center, so there's an app out that comes with this that basically will send a negative result to your phone, just like you would see your boarding pass would have that QR code. So this is interesting in terms of helping, prove that somebody's had a negative test relatively recently, and the fact that if the test is enabled and they've got the app on their phone, it can actually show up there. What shows up if you have a positive result is a message to your doctor and a message to you on your phone telling you to self-isolate. So all of these tests are available. The federal government spent quite a bit of money on this particular one, $760 million to order tests and supplies, and really wants to expand the use of this particular test across several different places, one of them being the skilled nursing facility market. I think the last one we have as an example here is an antibody test. This is a 94% positive and a 96% negative with a 15 to 20 minute turnaround time. So these are just a sample of the tests that are out there, but clearly, there's a lot of opportunity on the point of care side to add this capacity or these tests to an integrated approach to help manage the pandemic. Their turnaround times are certainly fast. So if that was it, we could just quit right now, but unfortunately we can't, and there are challenges and roadblocks to talk about. So with all these choices and tests and government reporting mandates, what could possibly go wrong? Well, here are the biggest things that could go wrong. The first is supplies. This is right out of Medical Laboratory Observer. If you look at the pie chart, 49% of our problems people would put in the supply category, and that's understandable as demand has been so high, and quite honestly, preparing for a pandemic has never been on anyone's, at least in the voters that I know, nobody was going to the polls and voting for people who were stockpiling pandemic supplies, at least in my lifetime. So I think these are things that we won't take for granted moving forward, and hopefully we'll have a better system in place for the next time that we need to deal with a pandemic. But supplies have been a challenge. Communication, I would put reporting in that same category, the ability to know what to communicate and then how to do it. Scaling up volume, personnel, just having the right personnel in the right place, and even big slice of PPE. That was one of our major challenges early for sure. We've spent a lot of money in the space of testing. The CARES Act was, trying to help sort of back support both healthcare providers and people doing the testing so that we could, build out a more robust approach to this. But a lot of rule changes, format changes in the information being reported. Where is it going? Varying levels of competence on the receiving end of all this information as well. So it has been very frustrating for organizations who have embarked on, this journey to stay current with the information as it changes, because it changes almost daily. So if we move to the next slide, if you thought throwing money at something would fix it all by itself, it hasn't. What the amount of money put into the testing world has done, though, is change where the bottlenecks and tie-ups have happened, right? So initially there were no supplies, then there were supplies, but maybe for the wrong types of tests that people wanted to run, et cetera, et cetera. So as demand has increased, the backlogs and choke points continue to evolve. I would say if somebody looked at where we are today versus where we were in March, they'd be astonished, and yet there are still a long way to go to being where we would like to be. It's not just that the pandemic problems are linked to testing either. It's certainly caused additional challenges for us as a country. Here's some statistics that are, quite honestly, a little bit stunning. and not good, right? So if, you know, a third of U.S. adults report stress and anxiety and sadness over the pandemic, that's not good. Certainly unemployment was really high, and the economic toll of the pandemic goes without saying. We've had greater than 200,000 deaths now since we've last updated this slide. The other side of healthcare and the impact of it really has been patients needing care have avoided it. And so we've had a higher number of cardiac arrests. We've had chronic conditions, especially in the area of cancer, go unmet. So we have all sorts of issues beyond simply testing issues that are impacting healthcare as a whole. And if your lab is part of a healthcare organization, certainly that would roll down to impact you as well. So you know, we're going to study this pandemic from a zillion different angles for years to come. I think we'll look at the role of the lab as part of that, which will be where we go next. How has it impacted? Let's start with lab revenue, right? Because you're running a business. If you're running a lab, labs were spending between $40 and $150 per test. If you go to the bottom bullet there, some of the reimbursements, you know, for some tests barely covered those costs. I think the reimbursement changes that have been part of the evolution of testing, we've pretty much landed on. For most of the large labs doing high throughput PCR testing, they've landed on that $100 reimbursement, and that's actually working for most labs in that particular space. Obviously, if you get into point-of-care testing or additional types of assays, there are certain CPT codes and reimbursement associated with those. I'm not going to go through and read these to you, but know that they're in the presentation if you need them. And you know, the point in the slide was just to show the varying levels of reimbursement depending on which type of test that you were choosing to do. Here are the high throughput hicks pics codes, U0003, U0004. I do want to mention the box at the bottom here. Neither hicks pics code should be used for tests that detect COVID-19 antibodies. We don't want to get you in trouble there. All right, moving along to one of the federal agencies that's you know, piping this money through. The Health Resources Services Administration was founded in 1982. If it wasn't high on your list of federal agencies to know a lot about, it wasn't on mine either. But they were awarded $2 billion. That, just to give you an idea, you know, sometimes we think millions and billions are kissing cousins. If you were to count to a million, it would take you 11 days, 1001, 1002, 1003. To count to a billion would take 32 years. So this is a lot of money. It's 2,000 millions poured right into helping through these various programs support organizations and efforts to ramp up testing. In particular, we really needed to focus money on treatment for the uninsured. The pandemic doesn't care whether you have insurance or not. And again, let's go back to the overall objective, which is to keep sick people isolated from healthy people so that we can, you know, sort of get our arms around the spread of the disease. There had to be a way to offset some of the cost of treating uninsured, and so there was $1 billion put into the Family First Coronavirus Response Act to do just that. So there's been a lot of money spent, but it doesn't fix everything, right? We still have challenges, and one of the challenges on the reimbursement side is simply the fact that we don't want to hold a single test up, and so we're pushing tests through, which creates, you know, a backlog of denials, which then hurts a healthcare organization's bottom line. These tests can be expensive, so if you're making mistakes either in QC or materials or on the insurance and reimbursement side, it can get very costly very quickly. So all of you have probably dealt with one of these issues as it relates to reimbursement challenges if you're in the COVID testing business. You know, the pandemic has changed, I would say radically changed workflows. This parking lot, we've got a couple different views of this, but you know, parking lot and drive-through testing wasn't really something we had on the radar screen a year ago. So trying to register, document, create instrument-ready labels at a drive-through testing site, creating interfaces that report the information that's mandated by the government to report to external organizations, and sending that information along on a daily basis to departments of Health and Human Services. The bottom line is, if you're getting into this business or already in it, to do this manually is darn near impossible. So some sort of a system to help you make sense. Certainly, we're seeing folks from around the country in different entities seek help in those ways, which is it's good. It's something that we've been proud to be able to help with a little bit. Some of the variations in normal revenue sources, back to the earlier slide on hospitals, almost everyone's reported a significant impact in their overall revenue. Histology and oncology taking a big hit. In particular, almost all revenue sources were down for 3 months, incrementally back up. Most are in the 92 to 98% of normal or pre-pandemic levels. If you add COVID revenue on top of that, if you're doing COVID testing, many folks are above their pre-pandemic levels in terms of just revenue, and there's still quite a lot of work to do to get our arms around this. So that's kind of the math on the dollars. Let's spend a little bit of time on the math on the turnaround time, because I think that's the need for speed. This is not what you want a high-efficiency lab operation to look like, but it's what we have, right? It's the kind of where we were. So if you're running a high-efficiency healthcare operation, this would not normally be your whiteboard for success. But you got to remember the objective, right? The objective is to isolate sick people from healthy people. And how are we doing on that in terms of time? We're not doing all that great. Our national reference lab turnaround times, typically 3 to 5 days, and that's been worse, up to 14 days. There's a limited number of tests that can be performed within a short turnaround time, and some folks took all the testing and then had problems getting it out, which increased turnaround time. So what do we do about that? Like, what are some options? Well, there's reasons for pressure on demand as we start thinking about improving, and I think as we think about adding point of care testing to this mix, which is where we're going, these are the reasons why even as we increase testing, we've had a hard time catching up, right? The virus is continuing to spread. Now we're testing pre-op patients. We've got nursing homes, prisons, and other federal facilities. We've got drive-through and walk-through community events. People want to bring their employees back to work, and the bottom line is delays mean we can't effectively meet the objectives that we have in terms of keeping healthy people healthy and sick people isolated until they're healthy. So we have to ramp this up in order to do good contact tracing. Turnaround time is absolutely critical. The last thing we want is for this last bullet to be true. Lagging test times can actually discourage people from getting tested and practicing social distancing, and we don't want to get why bother, right? We don't want the attitude of why bother. So you think about our supply chain is a little stressed. I think some of our experts are even showing some signs of stress. If you're going to do contact tracing and the test comes back in 5 to 7 days, you might as well not do it because it's already too late. So, we as Americans generally don't accept failure very well. So I think we're looking at this and thinking, how do we improve? What can we do to take a more integrated approach to this so that we have speed where we need it, and complementing that with the accuracy that we've all come to love out of the lab. And so the role of integrated point-of-care testing in our COVID-19 response. Or said another way, I feel the need for speed. Okay, so how many of you saw this movie? How many of you saw it more than once? I'm not going to tell you how many times I saw it, but I will say this about Top Gun. Flying Fighters was nothing like the movie. Although the competitiveness and the camaraderie were very well done, which is, so I'll say that. It has nothing to do with my presentation other than I digress. So off we go. If we're going to get our arms around the pandemic, we're going to have a lot of testing with shorter turnaround times in an integrated fashion. And so in order to meet these numbers, we're going to have to do something different. The federal government's realized that. They've started to bring point-of-care tests to the forefront, both for schools, businesses, skilled nursing facilities. And so, you know, if you think about the speed at which these tests can get turned around, we're starting to now get something that's a real tool in the toolbox. Now, again, take a deep breath here. I'm not saying it replaces PCR testing in the core labs. It certainly does not. In fact, with the government rules, as they sent these instruments out to our skilled nursing facility friends, you know, automatic reflex testing was part of the rule for somebody who was symptomatic or been exposed and tested negative. So it's just a way to bring speed into our approach to this, and as long as it's an integrated approach, these three types of tests should be part of how we try to get our arms around, you know, managing the pandemic. So as I said, on July 14th, was it? Yep, July 14th, HHS announced large-scale procurement of FDA-authorized rapid diagnostic point-of-care tests to be sent to nursing homes. So this kind of makes you feel like the old phrase, I'm from the government and I'm here to help. I'm sure for those of you on the line from the skilled nursing world, some days you feel like this has been less helpful versus more helpful. Again, if you're trying to do these things manually without some systemic help to help an integrated approach, it's probably going to be difficult. But this is a place, nursing homes, that really do need a speedy result in order to isolate our most vulnerable Americans. And remember, we're comparing a test that in some cases is 98% accurate to, you know, testing someone on the forehead with a thermometer. So it's not like we're saying or want to say that it's an end-all be-all, but clearly part of the approach has to be an integrated approach. So if you think about that from that perspective, and then look at these numbers, you know, we had more than 53,000 deaths among nursing home residents as of August 30th. I'm sure that number, like the rest of them, is up. But, you know, the testing czar here has pretty much said, let's figure out a way to bring this speed into our skilled nursing facilities and see if we can help manage that. So the need for speed is real, for sure. And remember, you know, remember the other option, right? It's something like this. Right? It's that or a screening questionnaire. It's something else that's certainly less accurate than a point-of-care test that has pretty good return. I think what we would say and what we want to one of the takeaways to be from the webinar is simply take a look at how this fits in your overall approach to managing the pandemic. It certainly is going to give a speedier result. It's not on its own going to be the only answer. Negative results may need to be confirmed with a high-sensitivity molecular test, an automatic reflex test. And I think it's also, this last bullet's important to remember. All testing is a snapshot at one point in time. So you could have a negative PCR test and 4 days from now be exposed, and, you know, if you had a PCR test 3 days later, it would, you know, might test positive. So important to remember, all testing, regardless of type, is a snapshot in time. So how do we get an integrated approach that brings speed where we need it? How are labs adapting to this reality? That's a challenge, right? We see our customers and labs around the country adapting in all of these ways. Add precautions to ensure safety, certainly create standard workflows or change workflows so that they are standardized in the sort of the new world. Segment certain instruments. We've had people add modules to LIS systems. We have people do nothing. Like some folks are business as usual and not doing COVID testing. So these are some common adaptations right out of out of MLO, and we're pretty much seeing all of these. Here's a case study. We know these folks; they're good people over at COPCP. Overview of their business. They perform about 4 million tests a year. They have 3 patient draw centers. Their challenge was getting enough supplies. It took weeks to months to purchase new platforms. They had real struggles there. But they did ultimately end up acquiring additional platforms. They did get their supply chain fixed and ultimately have ramped up their capacity to 90 tests per day. So this is not a reference lab. This is a medical group case study. So I don't know how many of you on there are from the med group world, but that's what this particular group did to meet the demands of their patients. Other folks have gotten kind of sort of collaborative in the way they go to manufacturers. In this case, 7 states banded together to go to the manufacturers and show that there was going to be continuous demand for point-of-care tests, which gave the manufacturers confidence to scale up production of those tests, and then the states could share where needed from that sort of buyer's consortium approach. A third and even sort of cooler approach is sort of the Shark Tank approach that NIH took. They had a Rapid Acceleration of Diagnostics initiative, which essentially allowed them as a government entity to infuse money right into technologies that would make a significant contribution. So this is pretty innovative for what is generally considered to be, you know, a government entity that moves slowly. So we thought that was pretty cool. And then, of course, HHS has done a lot in terms of reducing testing turnaround times. They've accelerated technology and authorizations through the EUA. Surge testing was another thing the federal government invested in through third-party setup testing where there were hot spots or where they felt like testing needed to be accelerated. Certainly have expanded capacity in almost every lab who's wanted to expand the capacity. Supply problems are still out there. They'll continue to be out there as long as the testing demand is as high as it is right now. And then finally, the point-of-care initiative, sending the point-of-care testing, the analyzers and testing supplies to nursing homes across the U.S. Those 2,400 have been sent, and many more than that. That was in the first 4 weeks. So there has been a large push across many different avenues to expand testing. So that kind of takes us to, you know, the lab's vital contribution. I think this is really important. As everybody scrambles to sort of meet these needs, you know, the lab and lab scientists really stand tall in this world. And I guess, you know, saying that another way, as I said in the beginning, we do love you, and I think the country has come to appreciate how important it is for lab scientists to be a big part of what's going on. So let me move to, this is a good example of the role that testing plays. If there's no testing, there's no data. And where we don't have any data, there's no meaningful way to manage the spread of the disease. And so you're right in the middle of that, and your knowledge of these systems, your knowledge of how to manage lab data and help others to manage it is really critical at this time. We go to, you know, looking at the different stages of COVID-19 from the earliest test, right? We're going to test to see if you have an infection and then, you know, have a diagnosis, yes or no. But if yes, the testing continues. We're going to stage and monitor that disease over the course of, you know, over the course of its progression all the way through to recovery and surveillance on the other side. And when I said that the pandemic is going to be studied for years, we'll be doing studies on the rate of antibody, you know, changes for a long time. So the lab is right in the middle of all of this. It doesn't matter, which stage we're talking about or what we're trying to accomplish within those stages. Laboratorians are right in the middle of it. Certainly, clinical labs and healthcare providers are right at the, first line of defense in any pandemic response. You're going to do that diagnostic testing. Going to be first to identify the causes of illness in communities. And I think, one thing we've learned, and I think the country will take as a lesson from this, is how important it is to maintain some sort of pandemic preparedness protocol. And I'd be the first one to say I think we were caught flat-footed on this. You go back to the beginning and the level of testing that we had through the CDC, it simply was never going to work. And I think, hopefully we won't be caught flat-footed again. In order to deliver on this, we need an integrated approach to the testing. There's going to be no way for us to get the turnaround times required in a pandemic response without an integrated approach. And I think this is pretty much illustrated in Kathleen's quote here. The public now has eyes on the lab. There's still much that people don't know, such as the limitations of antibody and other testing. We need to be better educators for the benefits of colleagues as well as patients. And this came from Kathleen David at TriCore. It's true. The laboratory medicine generally is, and I've been in healthcare for a long time. If you had 3 buckets of things to talk about, right? Let's talk about bucket 1, bucket 2, and bucket 3. Lab testing would generally transition between bucket 2 and bucket 3 in most healthcare conversations. For the last 6 to 8 months, it's been right at the top of bucket number 1. And so because of that, we need to take this opportunity as lab experts to help educate colleagues, to help educate our organization, to be, to let the expertise that you have shine through so that people can see your value, see the value of the lab, and you can educate folks who really do need the education in order to best benefit your organization and the country as a whole. CNBC even went so far as to run this as a lead story, the hidden professionals saving lives, talking about medical lab scientists. Now, again, go back a year from now or a year before the pandemic, these weren't the sort of stories that were running on headline news, but they are now. And I think what this says to you as lab expertise or as lab experts and lab professionals is the country does recognize your value, and as a nation, we love you. We can't show the link because we didn't get permission to do it, but we can provide the link so that you can take a look yourself. So be proud of what you've brought to the pandemic in terms of expertise, and there's still more to do. There's still more education that can take place. There's still things that need to be done. But when I say we love you, the whole nation loves you. So as we look to summarize the main points here, we need trade-offs to be made. The paradigm shift for lab is point-of-care testing really does need to be integrated into an approach to manage a pandemic. It's different than what we would call our normal, everyday, run-of-the-mill approach to testing. And so when we think about this, it's not perfect, but the trade-off's going to be worth it in specific scenarios. It does need to be an integrated approach because we're not going, there's never going to be a time when point of care on its own, just because it's fast, fills the need. We are going to have to reflex to more accurate tests in certain situations. So we have to have that integration built into our approach. And when speedy results are absolutely necessary, point of care is probably going to have to be part of that mix. Before I, get to my last slide or two, I think it's a good time, if there are any questions out there, start typing them up or send them over on the chat or however you might want to pose them so that we can get right to them as we wind down. But if you have questions, certainly send them along via the chat. And if I'm missing anything, Rick will probably yell at me when I'm done. But I think that'll be good. No, he won't yell. He never yells. Key lessons learned. Early availability of diagnostic testing is of great value for patient management and public health. I think we learned that lesson the hard way with this pandemic. Hopefully, as we move from where we are today, which is leaps and bounds from where we started, that'll be a lesson that we take and value moving forward. Development, validation, scale-up, and distribution of diagnostic tests should be a key priority as we prepare during any sort of emerging infectious disease outbreak. Again, that kind of goes to the first point. Multiple testing methodologies, venues, including rapid point-of-care testing, are beneficial to meet demand. I would say they're critical in order to manage a pandemic. There's no way, if you look at what we've had to manage here with turnaround times, that it can be done simply with a 3 to 5 day time frame. So some sort of an integrated approach is necessary, which is our fourth bullet. And then lastly, but not leastly, we do love you. Lab professionals have been a big part of moving the country to where we are today. Certainly will be a big part of moving us from this point forward. And we're proud, at Orchard to serve you with tools and help that hopefully can benefit both your organization and the country as a whole. So I think with that, I have left enough time for some questions. I'm not sure if there are any written. I'm trying to steer my way over to look. Rick, I'll defer back to you.
Well, thank you very much, Matt. Yeah, there are lots of questions, in fact.
All right, great.
And let's go to our first question. I'll go ahead and get us set up on our question slide just so that everybody knows, hey, yeah, these are questions.
Good.
First, and there are two questions I've put together here because they're both interesting. One is a statement. There have been a number of statements here that I'm going to share. If you've got any comments on that, Matt, please have at it. If not, I just want to make sure that everybody knows what people are feeling as far as this whole COVID testing situation is going. So first, we need a triaging of testing. Surveillance of people who aren't complying with preventive measures are eating up resources, and she says, i.e. Athletes. Next question, but the next comment is actually a question related to this. I'm curious about testing methods used in large sports bubble situations. There are lots of them. Everybody is familiar with these. Have they created personal labs or staff, I guess you're saying, to do the testing?
So I have to say I'm not sure what they're doing in the athletic world. We have not been asked to be part of that, to my knowledge, and somebody could correct me from Orchard if I'm wrong. I do know that for the universities around the country who have brought students back, and so and I think athletes were part of that sequence of events, that we have set up systems to help universities manage the students after they're on campus. Most of the students with the universities that we're working with before they show up on campus have had to do a test to prove that they're healthy enough to come on. But once on, we've set up multiple universities and expect that we'll continue to help universities set up testing in an integrated way that allows them to test and isolate students so that they can keep their campuses open. So that's the closest I can get to answering about the athletes. My guess is that they do have some sort of a system, or at least a very quick turnaround time for the tests that they are running, because they are running a lot of tests on a daily basis. Sorry if I don't have a more precise answer on the professional sports side.
Oh, no worries at all about that. And these questions are rolling in. So this is a really good question. Don't know if you have the answer to this, but it's a really good question and a tough one. Are the EUAs expiring, and how is the FDA doing with officially approving COVID tests? In other words, taking them out of EUA and actually approving them.
Yeah, so I don't have good visibility to that. It's not been something that I've spent a lot of time on. We have been asked which we couldn't help with because we really aren't set up to do this. But we have been asked to help government agencies who are trying to figure out which of these instruments, now that they're out in the field and doing testing, are actually, meeting sort of the claims that they came to market with. So I know that the government agencies who are monitoring testing are looking for the efficacy, for lack of a better term, the accuracy, and whether each of the instruments or tests that they've given EUA for are performing at the levels that they were told they would. I do not have any visibility into the analytics that the government's doing to come up with those answers, but I do know they're looking.
Okay, great, thanks. Next, point-of-care antigen testing is clearly not as accurate, but faster and lower cost. How does a lab successfully promote the integrated approach? Doing it right appears to require even more resources.
Yes, so I think that's a really good question, and it depends. It depends on what type of lab you're in. It depends on what the patient mix that you have is. I think if we go to the Central Ohio Primary Care example, they used point of care. They have a very big owned lab, a core lab that they run themselves, and then they extended point of care platforms into additional sites. I know we have several clients who are extending point of care out to some of their larger outpatient facilities, but still running reflex tests back to their core lab where required. And so I think the answer to the question is really it does depend. It does require more resources, and it depends on the objective that you have. I think the nursing home world has been asked to do point of care simply because they can't wait 5 days or 4 days to get a PCR result. I think if they could get a PCR result in 6 hours, they probably would just stick with PCR testing. And I do know some skilled nursing facilities have managed to get that sort of relationship with a reference lab that's close to them. But most don't have it, and most of the that core lab testing does need some additional help for where faster turnaround times are absolutely required. So it does take more resources. There is no simple way to approach that, but we'd be happy to help you think through it. We've helped a lot of people think through what they're trying to do, and then helped integrate a solution with them that met that objective. And we've had calls from all sorts of people. Universities was one example, but we've had calls from all sorts of entities who are thinking about this and trying to figure out the best way to go about it. So without knowing exactly what your situation is, it'd be hard for me to give a precise answer, sadly.
All right, well,
I almost sound like a politician there, didn't I? That was almost like a political answer, which is bad. I don't ever want to do that, so sorry about that.
No worries at all. So we did hear from Kim Futrell. Those of you who know Kim knows that she is very well connected, and she responded to the question about the EUAs and when they would, if they would be suspended and so on. So here's what Kim says. EUAs, and this is from the FDA, EUAs for COVID-19 will no longer be in effect once the declared health emergency is terminated, or they could be revised or revoked if it is appropriate to protect the public health or safety. Once again, that is from the FDA. Thank you for that, Kim. Next question.
Thank you, Kim.
Yep, next question for you, Matt. Are there any published statistics on the number of facilities performing point-of-care testing, serology testing?
Ooh. Kim might have to help me with that, too. I don't think there are any stats that are linked solely to serology testing. I do think people are aggregating data on point-of-care testing as a whole, but based on some of the queries we've had by analytics companies on behalf of government agencies, I think it's something they don't have their arms completely around. Remember, these tests went out, these analyzers and tests went out so fast to try to meet capacity requirements or volume requirements, that the measurements of them is lagging. And so I think you'll see those sorts of stats put together over time. I certainly think you'll see those stats in skilled nursing facilities, in nursing homes in general, because the government has put the equipment in, therefore expects it to be connected. So those sorts of stats I think will come, but I don't think on a whole that there'll be great stats on point-of-care instruments across the country for some time yet.
Okay, thanks. And I do have a response from Kim again. Kim, I may just open your phone here so that I don't have to be translating your voice, but I'll go ahead and read what Kim has just sent us. This is about the antibody testing. I do not think that antibody testing is widely used yet because we don't yet have a good understanding of what that means. Does a positive mean you're immune, and for how long? Do we need IgG, IgM total? What's the best time to test, asymptomatic or after recovery? I think there are more questions than answers around antibody testing, but I also believe that we will get there as the studies continue to gather data to help us gain a greater understanding. What we need is more data, more understanding of all this. It's been a while, but it's still early in all of that. So thank you for Kim for all of that. Now, we do have lots more questions, and we will get to more questions. However, we are just a minute away from our scheduled stop time, and I know that some of you may have a hard stop on the hour. If you need to get going, we thank you for joining us. Hope you stay safe out there. For those of you, though, who can stay with us, let's move to our next question. Do you think that we have learned from COVID-19 and our response, the laboratory's response, will improve going forward?
I do personally, yes. I think the American public and really probably the world as a whole will demand that we have a better response prepared. From our view as a software company in the middle of integrating all sorts of information related to COVID testing to government agencies, I think some of that integration will remain post-COVID-19. It will certainly help with other things that we manage, like normal flu season. But beyond that, some of the investment can be left in infrastructure that would support very quickly managing another pandemic. So I actually think we will be better prepared. Like everything, time tends to dull the pain of not being prepared, and so the longer we go without another health crisis, I think it's going to be on us as citizens to make sure that we do stay prepared, because I think over time it's easy to get a little complacent.
Hear, hear, and that's the fear. So the next, we still have shortages of personnel. How do we improve recruitment and retention?
Boy, that's a great question. I have thoughts, but I don't know if they're, I'm assuming you're talking about basically just lab personnel in general, and medical technologists are, a scarce resource out there. So assuming you're talking about med techs as a whole, and I don't know where you are in the country in terms of schools or access to, to new med technologists. I think one thing that could happen as a result of the pandemic and the focus on lab is, with any luck, we'll get people looking at the lab profession and lab medicine through a lens that may bring us new folks. It won't help you in the short term, but in the long term, hopefully, sort of the love that the country is giving to the lab profession may help steer people towards it. But Kim may have an idea. I know she's looked at this before in terms of med tech shortages. I'll defer to her, but I don't have any short-term solutions. I can say that for the people who we've helped or tried to help in this, we've, the ability to do things in an automated way, and I say that from integrating your systems, your reporting, the things that a lot of people are still trying to do manually. maybe it can free up enough time that the staffing that you have is better utilized in the spots that you want to utilize it. But other than that, I don't have any short-term ideas.
Well, you know, on that same vein, I'm just going to share this because there may be some other folks who have opinions on this as well or just agree. Lisa says, then the government needs to support increased training for CLSs instead of reducing educational requirements for testing personnel. So it's two challenges. One is the training, of course, and the other is just having the bodies, the trained personnel. Yeah. So, how has Orchard responded to the automated reporting challenges due to COVID?
So fortunately, we have some great tools to help with automated reporting. We have many of the public health labs around the country. Orchard is, you know, the LIS system for them. So as far as interfaces to the CDC or to state departments of health, those are interfaces that our integration team has written and that we've done. So as that gets extended out to entities that have never had to report, and again, I keep using skilled nursing just because it's become such a focal point for, you know, government involvement. Typically, you know, you would maybe do a little bit of point-of-care testing and then send testing out to a reference lab, and the reporting would be done by them. But as you put, you know, a network in place to manage some of this reporting yourself, then yes, then I think those interfaces and those tools that we have to make that reporting automated is key. And so doesn't mean we can solve every reporting issue. I think the disclaimer slide on the second or third slide, things change so fast across what's required or who needs information that as soon as I tell you we can do something the day after, I'll be wrong. But the reality is most public health reporting, Orchard has had tools and interfaces in place for a long time to do, and we're finding that people are grateful for that as they come to us for help with their challenges.
Great, thank you very much for that. Next, is there any data that you know of on the incidence of false negatives leading to outbreaks or hotspots in communities? Another good but tough question.
Don't have specifics, but I think that the rule that came with the point-of-care analyzers would say there are instances where that's the case, and the rules that came with them basically said if you get a negative on one of these point-of-care tests, but the patient has, you know, fill-in-the-blank symptoms, recently been exposed, you have other reasons to believe they might be positive, then you do an automatic reflex to a PCR test. So I don't have the instance in my hip pocket, but I would say based on that rule that there have been instances where, you know, where a point-of-care test, or any test, quite honestly, the first time didn't show a positive result when clinically it looked like there should be. I can tell you from a personal family situation that I had a family member test early in the pandemic. This was March, I think. Went to the hospital with all the symptoms of COVID, tested positive for flu, and they sent him home with what ultimately ended up being COVID, and he passed it around the family. Fortunately, everybody was fine. Felt bad, but got better. But that's a perfect situation where knowledge over the course of the pandemic has changed dramatically. Initially, they tested people for flu, and if you had flu, they assumed you couldn't have COVID too. They didn't even run a COVID test on him. They just ran a flu test. So a lot has changed. A lot will continue to change as we learn more clinically about what to do and what not to do. But I think based on the fact that negatives out of a point-of-care instrument when we think there's a reason to suspect COVID clinically, and the auto reflex to a PCR test would tell me that that's kind of the way to cover that instance.
Okay, great. I just want to share another comment because
sure.
we have so many smart folks here. We may want to clarify FDA's position on this because Martha says, per an FDA town hall, the FDA stated it has no plans to end EUAs or what to do with the testing and the CLIA once they end. So we'll see if we can get some clarification on this. Thanks for that, Martha, and thank you for that, Kim. They may agree with each other, but it's the phrasing that may be the issue.
It could be possible that two government agencies said conflicting things. I mean, that's possible. Just kidding. No, just kidding. I'm sorry.
Well, that's all. This is just one. This is just the FDA.
I know.
So here is another. We have time. Let's just take one or two more questions because we're really running so far over here. And thank you for the extra time, Matt.
Oh, you're welcome.
Is a CLIA waived type of test really intended to be scaled up to high throughput? And I'm not sure you can answer this, Lisa says. She's giving you that, but it's, again, a very good question, good thought.
No, I don't think so. I think what that's what we're advocating in terms of integrating those what we would call low throughput, CLIA waived point of care tests in a space or with a patient where time is more important in terms of a result than the more accurate test that you can send out. So it's I don't think anybody's advocating that you're going to move point of care to high throughput. It's simply where do you need that level of speed where the trade-off on the send-out can be made. And so integrating that or figuring out where that fits in your particular organization or certain types of patients, the government's kind of made the decision for nursing homes that they're going to use point of care in those facilities simply because the feeling is we need faster isolation of sick people. So I don't think anybody's advocating for, nor could we expect point of care tests to ever be high throughput. I think that's a fair question.
Okay, thank you, Matt. We'll take one more question, and we have so many more excellent questions here, but we'll take one more now.
But we can try to get to some of them afterwards as well, Rick, if there are things that we can answer. We won't take guesses at government questions. As soon as, like I say, we answer one, we'll be wrong, either based on the time that we answered in or a different perspective from a different side of an agency. So, but if there's something that we have expertise in a list of questions, we certainly will take a whack at answering some of them and sending them out.
Perfect. Thank you very much.
You're welcome.
Yeah, we'll make sure to get all those questions to you.
Okay.
Next, so the last question is, with the three different types of testing, particularly with point-of-care testing, do you think it's important for all types to be utilized?
Oh, that's a great question. That as I'm a non-lab scientist, right? I'm the business guy. My sense is that whatever equipment you feel that meets your threshold for accuracy, and I think everybody's got a different view of that. And these instruments most of them are fairly close. Some have a significant difference or delta. And what you're trying to accomplish with the results. For example, a university has one objective. We've had calls from airlines trying to think through how they might test either their own people or passengers. And so I think a lot of it depends on what the objective is for the business that you're running. If it's just pure lab, you're talking about a physician-owned lab that's part of a medical group or a hospital lab, I think you fit that in based on what the patient mix needs and go from there. So I don't think I would say, you automatically have to use all three types. I think I would look at what can I get supplies for, what's the patient mix or the patient business and clinical objectives that I'm trying to meet, where does that fit in terms of my access to a PCR test that's run at a core lab somewhere, and then based on all of those things, try to pick the instrument or the set of tools that best addresses those challenges. So again, we can help. We would never recommend a manufacturer. We can help people think through sort of what they're trying to accomplish and what they have in their toolbox at the time, and what additional tools might help them, we certainly are willing to do that for folks that are trying to think through. It's kind of a complex problem, and every situation's a little bit different.
Well, thank you so much, Matt, and all of you. Thank you for all of your nice comments about the presentation and Matt's ability as a presenter. Lots of those, so thank you. So a big thanks to you, Matt, really, for a wonderful presentation. Terrific job. Great presenting.
Thank you very much.
And a big thanks to our friends at Orchard Software for sponsoring today's event. Thank you for your help as well with some of these questions, Kim Futrell. And a big thanks goes mostly to all of you for joining us. We hope that you will do it again very soon, and also that you stay safe and healthy. And we thank you for all that you do every day on the front lines out there helping our population. So thanks, everyone, for joining us. We look forward to having you again with us very soon. Thanks, everyone. Have a wonderful rest of your day.